Before we begin, I'd like to make a brief land acknowledgement. McGill University is on land which has long served as a site of meeting and exchange amongst Indigenous peoples. We acknowledge and thank the diverse Indigenous peoples whose presence marks the territory on which we now gather. So to introduce our speaker today, who's coming to us from the Division of General Internal Medicine, we are very fortunate to have with us today the Deputy Director of the Research Institute, Dr. Louise Pilote. Please come forward to introduce our speaker. Thank you.
Good afternoon and welcome everyone. It really is such a nice pleasure for me to introduce Stella. I've had the privilege and pleasure to see her progress with her career and flourish, and it's such a great privilege to have her with us. So just to tell you a little bit about her, for those who don't know everything she's been doing. So she's a general internist with a special interest in vascular medicine, and she's actually a tenured professor in the Department of Medicine with an interest in cardiometabolic diseases, sex differences in cardiovascular diseases, women's health across the lifespan, and vascular disease prevention. Seems like a lot, but she can do it all. So her research program covers the continuum, as you can see, of arteriosclerosis and arterial stiffness and advanced arteriosclerosis, with a strong crossover between basic, translational, and clinical research. Stella has been very prolific with 230 high-quality peer-reviewed papers, 14,000 citations, and she already has an H-index of 61. She's been very successful at CIHR and FRQS and heart and stroke grants with over $7 million as a principal investigator. She's been the chair of Hypertension Canada Guidelines and is also part of the European Guideline Committee now. The guidelines on hypertension have just come out. And she's now the co-leader of the SHAL program, the Cardiovascular Health Across the Lifespan program of the Research Institute. And then we're really hoping that she'll be able to bring together all the cardiovascular talent in our institution to do even better. So without any further ado, I will invite you to listen to Stella to speak to us about understanding the role of sex in hypertension, implications for personalized medicine.
Good afternoon. Thank you so much for this nice introduction. It took all the time from the presentation, but that's okay. Thank you very much, and thank you for the invitation and the opportunity to talk about sex in hypertension. And I hope you think of the right thing. So my disclosures, I don't have anything to disclose except for my grants, the funding from peer-reviewed agencies. And then I just want to make a disclosure that when I refer to biological sex, I mention females and males, but sometimes I may say women and men, but I use these terms inclusively, particularly because some of the papers actually use women and men for the biological sex. So we'll talk today about epidemiological data on prevalence and control of hypertension in females and males, hypertension in females across the life course, treatment of hypertension in females and males. So it's a lot, so fasten your seatbelts. So, and we'll start with Miss L, and let's meet her. She's a 57-year-old female. She's sedentary, has a high blood pressure or elevated blood pressure of 143/89. She has a history of preeclampsia. She has obesity or overweight. Actually, she has excess weight. She's pre-diabetic, a smoker, and she has dyslipidemia. Her overall Framingham risk score is 5.8%. And as you can see, she actually has all the components of the metabolic syndrome. So would you treat Miss L? So let's see. So let's talk a little bit about the epidemiological data. So high blood pressure has been and remains the #1 killer in the world, including developing and developed countries. And in fact, hypertension accounts for about 1 in 5 deaths in females. And so this has been consistent, but in an update, recent update in 2024 of the American Heart Association, it has been shown that males have higher prevalence of hypertension compared to females, blue and red, of the same age group. but this is until the 6th decade of life. And then there is a flip. And what's important is that the age-adjusted prevalence of hypertension is actually 75% for older females and 65% for older males. And so this update also looked at race and ethnicity. And obviously, as we know, Black race is associated with higher prevalence of hypertension. And in fact, this was from NHANES survey, and there are 3 time periods. And as you can see, Black males actually have a slight decrease over the time points, but females have actually a slight increase, to the point that in the latest survey, females actually have a little bit higher prevalence of hypertension compared to their male counterparts. And so let's see what is happening in Canada. Although the prevalence of hypertension in Canada remains stable over time, about 25%, what we know is that awareness, treatment, and control is actually decreasing in recent years in females. You can see all 3 are decreasing while male is about stable. And this is true particularly in older females. And so analysis of 4 community-based cohorts, very well established, Framingham, Cardia, Aric, and Mesa, including around 33,000 people, showed what we know already, that as we age, men and women, the blood pressure tends to go up, systolic blood pressure, and women kind of, as we said before, catch up in around the 6th decade. And diastolic blood pressure drops, the known drop, and pulse pressure is actually about the same for males and females. So the conventional view is that males are worse off and females catch up with age. But so what if we take a different view of this, and we actually look at the compare the older females with the younger selves and older males with the younger selves. In other words, we are looking at the trajectory within person. So in this case, we see that there is a steep elevation in blood pressure from base. And so in fact, this is kind of the same analysis showing that this incremental blood pressure elevation from baseline levels is particularly seen, obviously in all of them, but particularly in the systolic blood pressure and pulse pressure. So now, using the same cohorts, 4 cohorts, they looked at the cardiometabolic risk factor burden. And so they looked at the 4 well-established risk factors: obesity, diabetes, hyperlipidemia, smoking. And if you had 2 or more cardiovascular risk factors, then you were considered to have high risk burden, and then you have less than 2 low risk burden. And look at this: if you have greater cardiovascular burden, when there is greater cardiovascular burden, females actually increase their blood pressure much steeper than males. And this is true for the overall systolic blood pressure load. Not only that, but it's consistent across the age groups, where you see that females are worse off compared to males. This is important because hypertension poses a greater cardiovascular disease burden in females who actually develop more adverse pathophysiological consequences, including acute myocardial infarction, stroke, left ventricular hypertrophy, atrial fibrillation, heart failure with preserved ejection fraction, increased arterial stiffness, diabetes, chronic kidney disease, and name it. And in fact, a large meta-analysis showed that for each 10 millimeter mercury increase in systolic blood pressure, females have 25% increased risk of having cardiovascular disease compared to males who had 15%. So, and let's look at some of these consequences. So, blood pressure is a stronger risk factor for MI in females compared to males. So, in general, males have more MIs, but if you have high blood pressure, you have a relative risk of more than 80%, and you are a female, to have an MI. And this has been shown consistently in large cohorts like the Interheart, UK Biobank, the Tromso studies. Not only that, but this is not only shown in older individuals, but also in young individuals. And just stage 1 hypertension in young females gives you double the risk of having MI than males. Look at these studies, particularly the Korean study in 6.5 million people, mean age 30, follow-up 13 years, double the risk of MI. Importantly, antihypertensive medications reduce the risk of MI in females to a lesser extent than in males compared to normotensive counterparts. What about stroke? Adjusted risk is increasing with increased hypertension severity, double in females, and also double the risk of developing left ventricular hypertrophy. And antihypertensive therapy actually reverses LVH to a lesser extent in females. What about the cognitive decline? And this is a very nice paper done by Dr. Pilot's group, where they analyzed the UK Biobank, and they found, although that there's no difference in cognitive decline between sexes over a 5-year period, there are certain, the impact of certain risk factors was more pronounced in females, particularly high blood pressure, increased LDL, and low education. And this confirms other studies that have shown that hypertension is actually a stronger predictor of dementia and cognitive decline in females rather than males. And this comes from our hot off the press European Society of Cardiology guidelines, where it summarizes the pathophysiology of elevated blood pressure and hypertension. It's very complex. Hypertension is very complex, and it's a complex interaction between renal, vascular mechanism, neural, hormonal, as well as genetic, behavioral, environmental, socioeconomic factors. And of course, there are several. Most of these factors are common in men and women. For example, excess weight, 20 to 30% of people with excess weight have hypertension, and you have 2 to 6-fold increased risk of hypertension when you're overweight. Also, physical inactivity, increased salt intake, diabetes, alcohol, obstructive sleep apnea. But there's also, importantly, sex-specific processes that lead to link hypertension or lead to actually the development of hypertension. So let's take a little journey in females' life. So females have several challenges, hormonal challenges, and there are several risk factors that actually increase the risk of developing hypertension across their life cycle. And we all know the beneficial effects of estrogen on the vasculature. Estrogen provoke vasodilation, and this can be done directly in the arteries, in the smooth muscle cells, but also it can be done indirectly, where there is increases in nitric oxide, decreases regulation of the vascular remodeling, as well as modulation of the sympathetic nervous system and the renin-angiotensin system. And just a quick reminder of the classical RAS, there's angiotensinogen that it's converted to angiotensin 1, and through ACE converts to angiotensin 2. So this acts through the AT1 receptors, causing vasoconstriction, sympathetic activation, cell proliferation, etc., and eventually leading to hypertension and arteriosclerosis. However, there's also the AT2 receptors, which have the opposite effect. They lead to vasodilation, inhibition of cell growth, and apoptosis. And in this process, the ACE2 is actually quite important. It's a potent counter-regulator against ACE, leading to vasodilation. So estrogen, actually, what they do is they decrease renin, ACE, the density of the AT1 receptor, NOX1 and NOX2, and the increased angiotensinogen ACE2, AT2 receptor density, as well as NO, nitric oxide synthase and nitric oxide. In other words, favor the vasodilatory branch of the RAS. What about androgen and testosterone? This is really a mess. So in the literature is very controversial. What most studies showed is that the acute administration of testosterone actually has a vasodilatory effect, but actually chronic long-term exposure seems to be associated with vasoconstriction, arteriosclerosis, and stimulation of the RAS. Not all studies agree with that, but most studies agree that exogenous administration of testosterone, like testosterone replacement therapy, actually is associated with unfavorable vascular effects. In other words, endothelial dysfunction, lipids, hypertension, and eventually arteriosclerosis. Kind of, this is a summary of what I said. And so women really undergo several hormonal changes throughout their life, and started with the menarche, there's menstrual cycle, there's oral contraceptives, pregnancy, lactation, menopause, and aging. And so for the sake of time, I will concentrate only on pregnancy and menopause, but if you want in the question, we can discuss the others. So pregnancy, there is hypertensive disorders of pregnancy. As we know, these are the types. There is chronic hypertension, gestational hypertension before the 20 weeks or after the 20 weeks, preeclampsia, which is associated with which is defined as new onset hypertension with proteinuria and or end organ damage, and chronic hypertension with superimposed preeclampsia. So preeclampsia is a heterogeneous progressive multisystem syndrome, and it affects 5 to 8% of pregnancies, but in high-risk pregnancies, it can be anywhere from 8 to 30%. So it's a leading cause of maternal and fetal mortality worldwide, accounting for 70,000 maternal deaths and 500,000 fetal deaths yearly. And there is early onset, less than 34 weeks, where there is usually more compromised trophoblast invasion and placental disturbances, while in late, which is the most common, 80 to 90%, more than 34 weeks of gestation, it's more associated with pre-existing maternal conditions. So in the US, preeclampsia has doubled in the last decades, and in Canada, the same. In Quebec, it also doubled, but unfortunately, we don't have more recent data. Maybe it's now even more. But the earlier data that we have showed exactly that it's almost doubled. And this could be because of the obesity diabetic epidemic, as well as the advanced maternal age. What is interesting is that ABPM studies are ambulatory blood pressure monitoring studies between 6 to 12 weeks after delivery revealed a high rate of sustained ambulatory, nocturnal, and mask hypertension in cases of preeclampsia. And so obviously we know that preeclampsia is associated with short-term devastating potentially consequences, but importantly, there's increased lifelong risk of chronic hypertension and complications. And I can give you some examples here where the nurses' health study has shown that it's associated, preeclampsia is associated with risk of chronic hypertension, that it's more than double, and also the risk of developing stroke, coronary artery disease, and CKD is also double. Other studies have actually shown even more, almost a fourfold increased risk of chronic hypertension. And importantly, they showed that there is an association with the severity of hypertension. The more severe, the preeclampsia, the more severe the preeclampsia, the higher the risk of developing chronic hypertension. And the same goes for the premature cardiovascular disease, which can be from 2 in mild to almost 10 in severe preeclampsia. So the million-dollar question is, preeclampsia, is it a risk factor or is it a consequence? that it's manifested that's underlying conditions that the pregnancy reveals them. So, or maybe both. We don't know what is it, but we all agree that really pregnancy is a metabolic stress test. And that's kind of a summary of what I said before, where you can see that hypertensive disorders of pregnancy shouldn't be taken lightly because they increase cardiovascular and other complications later in life and as soon as 10 years after delivery. And so everybody who knows me, actually, no, I'll say that first. The American Heart Association, even since 2011, has recommended that we should include a history of pregnancy complications when we assess the risk of vascular disease in females. We don't do it in clinical practice. So people who know me know that I have a passion for arterial stiffness, and also in the context of pregnancy. So we performed the REVEAL study, and the idea behind this was to predict preeclampsia early. And so we looked at arterial stiffness, and we found that actually arterial stiffness can predict earlier in the first trimester, and with greater ability preeclampsia compared to the known and so far available predictive tools, including blood pressure, uterine artery Doppler, and angiogenic biomarkers. And that was with an AUC of 0.83, where we found that the first trimester 1 meter per second increase in carotid femoral pulse wave velocity was associated with a 64 increased odds for preeclampsia. And carotid femoral pulse wave velocity is kind of the gold standard measure of arterial stiffness because it measures the elastic arteries, including the aorta. So we also looked at the longitudinal changes of arterial stiffness, of carotid femoral pulse wave velocity, and other indices. And we found this interesting observation. We had this interesting observation. They were all high-risk pregnant women, but those who were destined to develop preeclampsia early in their pregnancy, early in the second trimester, between 14, 17 weeks, they have a change point. We did a Bayesian analysis, and we found there was a change point where women who eventually developed preeclampsia had an increase, while women who did not develop preeclampsia had a nice decrease, showing a nice U shape, which is the natural response of the vascular system, where there is a nadir in the second trimester in order to accommodate the needs of the increasing the developing fetus. So all this data were the platform for introducing or designing actually the PULSE study, which aims to expand and validate our REVEAL data. And in fact, I have to disclose that because it's not disclosed, but basically say that I was very happy because this was a very large study, funded study from CIHR, and it will never happen to me again, but it was funded in the first try and ranked first. So that happens once in a lifetime, at least for me, I think. So it's a multinational study. We target 2,400 individuals, pregnant people with high-risk singleton pregnancies. We have 10 sites, and we may expand more. And for now, we have already recruited more than 1,100 people. So stay tuned. I may come to show you interesting results. So the other very sensitive period of life in females is menopause, where we know that menopause transition coupled with aging leads to endothelial dysfunction through oxidative stress, inflammation, decreased estrogen receptors, and dysfunction of enos, as well as large artery stiffening, and eventually leading to cardiovascular disease and events. And so just to explain a little bit the stiffening here. So if you are young and beautiful, you have good vascular distensibility, your aorta is actually a buffer. So what it happens is that during systole, the stroke volume is kind of stored in the elastic aorta. And so a smaller portion is transmitted to the periphery. And during diastole, there is recoil. So the rest of the stroke volume goes to the periphery. So there is continuous perfusion. However, when your vascular stability is impaired, what happens is that there is not this elasticity during systole, so most of the stroke volume actually goes to the periphery, and small portion is transmitted during diastole. What is the result of this? We have increased systolic blood pressure and decreased diastolic blood pressure, and as a result, we have increased pulse pressure, which, as we know, is the arterial stiffness measurement of the poor. So we have I'll show it to you actually in a illustration. So this is the pulse pressure that it's sent from the aorta, and then because of the branching and the arteries get smaller and smaller, there's a forward, there's wave reflection, and there is a backward wave. And basically the two waves combine, and this is actually in red what the aorta senses. Now, when you have stiffer arteries, what is happening is the reflected wave travels faster into the systole and less into the diastole. And as a result, we have, as I said, increased systolic blood pressure, increased LV load, and decreased diastolic blood pressure. And we know that this is very important because diastolic blood pressure is the phase where the heart feeds itself. So now to this end, when we look at the association between arterial stiffness and age in females, we see that there is a quadratic curve, and this curve is actually very steep during menopause. And the arterial compliance tends to decrease through the phases of the menopause, starting actually in the early perimenopause. So with Dr. Pilot, we performed this nice study, the BRAVE study, where we found that abnormal blood pressure variability is common in normotensive, even normotensive perimenopausal women, and the maximum overnight blood pressure is independently associated with arterial stiffness. So now hypertension in elderly females in general, we know that elderly females have more severe hypertension, have lower blood pressure control rates versus middle-aged females and young females, and also versus males. And this is potentially due to several biological factors, but as well as physician inertia, lack of adherence, or inappropriate drug choices. And this is evidence that we have from many, many years ago, but still the evidence is the same, and some things never change. Does sex matter? I don't know in this case, but definitely in hypertension it does. So we know that there's sexual dimorphism in age-related blood pressure elevation, and this is multifactorial. Just to wrap it up. Sex hormones are very important, but they are not the only drivers of sex difference across the life course. As I mentioned, is a complex interaction of several factors. And in fact, there's polygenic risk factor scores that seem to be different in males and females, and sex-specific gene expressions. But what I find interesting is to mention that females not only have smaller total body size, but also they have smaller organs and smaller vessels, even after adjusting for body surface area. And that could explain why the burden of risk factors on females is actually greater. Remember, I mentioned about the cardiovascular, cardiometabolic burden that found to be greater in women. So with this evidence, one could wonder, should females and males actually have the same blood pressure thresholds? And so an earlier study has shown that actually we may need to have lower thresholds for females. And here you can see awake, systolic, awake, diastolic, asleep, systolic asleep, diastolic blood pressure. For a change, males are in pink and females are in blue or purple. So you can see in all cases, actually, the cardiovascular risk, the total risk of cardiovascular events is actually starts at a lower level in females. And so this analysis based on the outcome of this analysis of diagnostic thresholds based on outcomes showed that probably females should have 10 millimeters lower systolic blood pressure and diastolic blood pressure 5 millimeters compared to males. However, should that be even lower? So as I mentioned again, this nice cohort of the 4 studies showed that the risk actually increases from blood pressure over 100 to 109. And although in men, this risk increases for cardiovascular events, including MI, heart failure, and stroke, in much higher blood pressure levels. And in fact, we see that at each level, women are doing worse. You can see it actually here, even better, where you can see there is an inflection point around blood pressure of 160. So I hope that we all think that Mrs. L now needs to be treated. So let's talk a little bit about hypertension treatment and outcomes in females and males. So there are sad truths like this one. Be nice to your kids because they'll choose your nursing home. But there is also this truth that females are underrepresented and at best are up to 40% in major trials. Even the SPRINT trial included only 36% of females. And the SPRINT trial was a landmark relatively recent trial that showed that treatment of high blood pressure to a level less than 120, targeting less than 120, is associated with cardiovascular benefit when compared to blood pressure targeting less than 140 millimeters mercury. So the lower, the better. But even that included only 36% of women, although they wanted to recruit 50%, but the trial ended earlier, prematurely, so then that could be a reason. Also, there is no direct comparison of treatment efficacy in females versus males. And so the evidence is derived primarily by extrapolation, subgroup analysis, or even adjustment. Statistical adjustment. So I'll give you the bottom line. So in general, there is no evidence showing that there are major difference in treatment efficacy in females versus males. And I'll show you a little bit of the evidence after, but I think this is kind of the take-home message. And the absolute risk reduction in females, the benefit was seen to be associated more with reduction of strokes, where in males, treatment prevented all cardiovascular events. So some landmark trials like the OLHAT and VALUE showed that in terms of blood pressure reduction, there was a greater, it was greater in females on calcium channel blockers. And in terms of cardiovascular outcome, OLHAT showed that CCBs were superior to diuretic and ACE inhibitors in reducing strokes in females. The VALUE trial showed that CCBs were superior to ARBs in reducing, or to the ARB valsartan that they checked, in reducing cardiac morbidity and mortality in females, but not in males. However, the Women's Health Initiative did not actually show that there was superior effect on CCB, particularly in postmenopausal women, and suggested that treatment with diuretics was equal or even superior to other medications. And diuretics may work well, especially in older women, because there's volume retention, like loss of estrogen triggers the RAS system and the salt-sensitive hypertension. So now, the blood pressure lowering treatment trialist collaboration included 31 RCTs, a large number of females and males with hypertension, and it showed that there is no significant difference in cardiovascular outcomes between males and females. And all antihypertensive treatments conferred equal protection against cardiovascular events in males and females. Also, when they did a subgroup analysis where they looked at people with higher cardiovascular risk and concomitant diseases, again, there was no clear difference in females versus males. Also, a large meta-analysis of 31 RCTs looked at the blood pressure lowering and major cardiovascular events and compared the effect between males and females and found that there was no difference in blood pressure lowering regimens versus placebo or less intensive control, ARBs, or based on the different drug classes. So basically, male and females responded the same. So what about medication use? So the Stockholm Regional Healthcare Data Warehouse showed that females are prescribed lower number of antihypertensive medications, and females were more often prescribed diuretics, ARBs, and beta blockers, while male more often ACE inhibitors and CCBs. However, they didn't look at the blood pressure controls in males and females. Now, a meta-analysis of 46 population-based studies in 22 countries, again, large number of males and females, showed that females were prescribed mostly diuretics, where males more often beta blockers, ACE inhibitors, and CCBs. So the other thing that is really important to mention is that females have more drug-related adverse events. So they have more cough associated with ACE inhibitors, more peripheral edema associated with CCBs, and more hyponatremia and hypokalemia related to diuretics. And that could be because there are physiological differences. There are sex difference in distribution of volume, in drug clearance, and in the CYP enzyme activity. For example, females have more active CYP3A4, which is responsible for the metabolism of CCBs and statins. And so sex difference in the absorption and distribution, as well as the excretion of the drugs, are responsible for sex difference in pharmacokinetic and pharmacodynamic studies, which may arise from difference in body composition, plasma protein binding, metabolizing enzyme and transporters, excretion activity, and or physiological hormonal changes. So we really need to look into that more closely and beyond epidemiology to do more basic assessments to actually see these differences and which medications act better in females or males. So how are we going to treat poor Mrs. L? So for sure, we cannot beat the behavioral modification. And this is from the latest Canadian hypertension guidelines. So physical activity, of course, we know that even regular actually aerobic activities has been associated with 7 to 8 millimeters mercury decrease in systolic blood pressure and about 4 to 5 decrease in diastolic blood pressure, which is really substantial. Obviously, we recommend weight reduction, like a normal weight, alcohol consumption. Now the new trend is even none, if possible, diet, fruits, vegetables, Mediterranean or DASH diet, sodium intake reduction, and stress management for those who have stress. So, but in terms of pharmacological therapy, actually, the guidelines remain sex agnostic. So there is no difference guidelines for males and females. And we recommend for adults who have no compelling indications to have any of the 6 first-line treatments, diuretics, and we prefer the longer acting, like thiazide-like, ACE inhibitors or ARBs, long-acting CCB, beta blockers for younger people, and then single pill combinations, which could be ACE with CCB, ARB with CCB, or ACE or ARB with a diuretic. Actually, we are proud in Hypertension Canada because we are probably the first and maybe still the only committee, Hypertension Guidelines Committee, that introduced guidelines for pregnancy, hypertension during pregnancy and lactation. But we haven't yet introduced sex-specific guidelines. And so what we can see from here is that there's a lack of strong and direct evidence to actually support recommendations to treat males and females differently. And so what might be very, very important is actually the global individual cardiovascular risk rather than the sex. And that could be a stronger predictor of future cardiovascular event and should guide the treatment of hypertension, not just the level of blood pressure. And the level of achieved blood pressure might be more important than the medication use. So that's the evidence that we currently have and we go about. And so a few words about gender differences. So there is the Constance's cohort, a large cohort study, where in a cross-sectional analysis, you see 60,000 people, found that there is a much stronger relationship between hypertension prevalence and socioeconomic deprivation in females, and particularly in the younger age group, and particularly related to education. So they looked at education, income, and residential deprivation. And you can see actually that in all cases, females are doing or women in this case are doing worse until like after the sixth decade where the lines or the trajectories converge. So the importance of education has been also shown in another large study in the Salurbal, which was from 230 cities in 8 Latin America countries. And they showed that higher education was also actually associated with lower odds of hypertension, particularly in females. And so that, I think, summarizes the gender differences in terms of hypertension and everything else. So a call to action. So we are very privileged to actually have an amazing group of giants in hypertension and other fields. And we were acknowledged as a McGill Department of Medicine world-class team on precision hypertension. Also, in terms of the RI MUHC network competition, we advanced to the final stage with our hypertension and vascular diseases network. And so with this, we aim to actually promote individualized care and particularly look at sex difference and women's health. Also, we're in the process of doing a systematic review and meta-analysis, gathering all the data from the beginning to now and looking at the efficacy of antihypertensive treatment in males and females. So hopefully this evidence will actually inform guidelines. But importantly, hot off the press, we have the 2024 European Society of Cardiology guidelines for the management of elevated blood pressure and hypertension. And one of the two co-chairs was Dr. Tars, who did an amazing job, actually. This is a masterpiece. It's 107 pages. I urge you to flip through, and it actually is one of the very few, or if not the only one, guidelines that included sex throughout. So showed the evidence that we have, or the lack of evidence that we have in terms of sex difference in hypertension, risk factors and management, diagnosis and management. And so in conclusion, hypertension is a major risk factor for females. And in fact, if you don't have high blood pressure, then men are worse off. But if you have high blood pressure, then you have a greater cardiovascular risk than your male counterparts. Blood pressure thresholds and targets may need to be actually lower in females. From what we've seen, we don't have the level A evidence from clinical trials, but the epidemiological evidence points towards that. And that raises the possibility of sex-targeted primary cardiovascular prevention. We've seen that there are hormonal changes actually across the life course that affect the blood pressure, but there is no clear indication for now for specific antihypertensive medication in females, possibly due to the lack of sex-specific studies or trials. And obviously, blood pressure should be, or hypertension should be treated through a multidisciplinary approach. And it's not just the physician, it's the nurse, it's the pharmacist, it's the dietitian, it's the psychologist, that they should all work as a team to reduce the level of blood pressure, reduce hypertension, and improve cardiovascular outcomes. And so with more studies, hopefully, we'll have sex-specific studies and geared towards females in particular. Hopefully, we'll have strong sex-specific guidelines that can guide us. In the era of precision medicine, we cannot be sex-agnostic. We need to place sex on the agenda. Thank you very much.
Thank you very much, Stella. First of all, thank you for this wonderful presentation, really comprehensive. But most importantly, I want to congratulate you and obviously your team here at McGill for the terrific work you've done, putting us on the map in this area, and for being such a great mentor to researchers here. You have stuck to your, over the years, I've seen you sort of stick to your plan and you're executing it exactly as one should. So congratulations on all your success. There's quite a few questions on the chat that are coming in. Something about, you mentioned stress reduction as part of treatment. What is evidence of perceived stress as a risk factor?
Yeah, that's a great question. It's actually, it's perceived it's always perceived, I guess, the risk, the stress. So it's a major risk factor. It has been shown in many different, actually, studies that it increases the risk by 2 or 3-fold of hypertension and eventually cardiovascular events. So that's why it has been introduced in the guidelines for many, many years. Stress management, if possible, through meditation or other measures.
Fantastic. Any relation to income levels? What is the role of parity and non-parity? Let's go with the income levels. Any relation with stress and income levels?
Yeah, there is a lot of evidence, not only in cardiovascular, but in any actually other condition, that low socioeconomic status, I guess that's usually goes, low income goes with socioeconomic status, is associated with increased risk of hypertension and cardiovascular events. So I don't know what is the solution to that, but getting a better job maybe.
Yes, that's right. What is the role of parity, nulliparity? So I guess people who've had kids or no kids on pregnancy-related complications who do not.
So we know that nulliparity is a strong risk factor for preeclampsia and hypertensive disorders of pregnancy, and so this is one actually in the list of on the list of risk factors is actually one major risk factor. Nulliparity. So, and obviously, if you have a preeclampsia, among others, if you have preeclampsia in a previous pregnancy, so definitely increases the risk of preeclampsia.
Ingrid, I hope we answered some of your questions there. If there are more, maybe you could speak to Stella about this. Okay, question from a man in the chat. If women have worse outcomes than men in almost all types of CV disease, because I think we'd like to talk about that.
So if women
have worse outcomes than men in almost all types of CV disease, how do you explain that women on average live longer than men? That's kind of a little bit more of a tricky question. Any comments on that?
Well, they live with disease. because we are doing a good job as medical doctors. And in fact, that has been shown that people now tend to have disease before, like if you think about this 30 years ago, who was talking about premature cardiovascular disease? Like it was unheard to have, particularly as a woman, premenopausal in your 40s having a heart attack. And here you go. Now it's kind of common. So we live longer, but we live with disease and the medication help us.
Okay, good answer. You show estrogen favors ACE2 or vasorelaxation. Have there been studies or observations in estrogen replacement in menopause on BP in those with hypertension?
Yeah, that's a very good question. In fact, there's a lot of controversial evidence. It used to be favor, yes, get a replacement. But in fact, several studies, as I said, have a very controversial results. And it seems that it comes down to timing, mode of delivery, like oral, transdermal, or transvaginal, that actually transvaginal has been shown to be associated with the least cardiovascular, unfavorable cardiovascular outcomes. Timing close to the menopause, because 10 years after, it's the same thing as with diabetes. The damages are already established. So definitely it has been shown that particularly transvaginal has much less risk. It's minimal, the risk. And if it's given early on, then, and obviously, like if you don't have progesterone, this all help to reduce mostly the postmenopausal symptoms that you have without affecting negatively your cardiovascular risk, maybe even improving. But we don't have yet these trials to show that for sure. It's more epidemiological evidence.
Okay, thank you. Given that women have more adverse events than men regarding BP meds, you feel that weight loss and activity play a particular role for BP control in women?
Physical activity.
Yeah. Yes, so.
Yes, absolutely, and it's not only men. It's only females. It's both males and females. Obviously, the first thing we have to do is lifestyle, or we call it now behavioral modification. So no medication can replace that. You cannot shovel in, like hamburgers and then like take the medication and expect that your risk will go down. So everything goes together. You have to do the behavioral, and then the medication helps. The medication doesn't make your risk zero. It reduces your risk, obviously, as we know. So as I mentioned before, the exercise actually has the most major effect. And as I said, regular aerobic activity has been shown to reduce the systolic blood pressure by 7 to 8 millimeters mercury, and diastolic by 4 to 5. This is more than some medications, actually. So it's very, very important.
Question here on diastolic BP. So is mean arterial BP, diastolic plus 1/3 pulse pressure, any better way than assessing BP rather than systolic and diastolic? What is the role of MAP in this context?
Depends on who you ask. If you ask the ICU people, they will tell you MAP is more important. If you ask the cardiovascular people, they tell you the pulse pressure is more important. So because the MAP, it shows the continuous kind of perfusion, while the pulse pressure shows the stiffening of your arteries, which is associated with cardiovascular risk. So I don't know if this answers, but yeah, well,
what do you
both are important, actually. And in fact, we sometimes, not many times, or always, if we can, we adjust for MAP in the cardiovascular studies that we have.
Perfect. Louise, you want to come and ask your question?
There's sort of an ongoing natural experiment in transgender medicine where you give estrogen to born males. So what is the effect on the blood pressure in these populations?
I can tell you the opposite. So there are some studies, there are mostly studies actually on transgender females that become males, where they take testosterone, and we have seen that they have worse outcomes. They have more higher lipids, more endothelial dysfunction, more hypertension, and eventually more arteriosclerosis. So exogenous, that's why exogenous testosterone, it actually seems to be kind of more detrimental. The estrogen, I'm not really sure. I have seen something like much about that, but hopefully they're good for us.
Fantastic.
I haven't seen much in this area. It's more on the testosterone, because the estrogen was never a question. Like the estrogen is more well established. What is really more controversial is the testosterone.
So we're coming up on the hour, so we're gonna have to close the rounds in a minute. If there's any other questions in the room, you can ask Stella. I'd like to close with, I see this really nice little comment from Isabelle Malame, and I fully agree with it. Congratulations, thank you so much, Stella, for your inspired leadership in this area and your mentorship in women's CV health for many years for many of us in the Department of Medicine over the years. So I echo that comment from Isabel, and I think we're very, very fortunate that you are here and guiding us along the way. So thanks everyone for joining us. Thanks for everyone in person. Thanks for everyone online. We will close out the rounds. It's coming up to 1 o'clock. Thank you.
Thank you very much for having me. Thank you.